So this is not a joke. We are live at SSF, and on behalf of our colleagues at Texas Back Institute, and I'll ask Dr. Geyer to say something in a second, and Dr. Ziegler and Dr. Blumenthal. It is a particular pleasure to introduce today's program. Again, one of the mainstays, the University of California, San Francisco program led by Dr. Sig Bervin on one of the most critical topics that engulfs us in spine care, and that is the correlation of pain, pain management, and back care. Rick from Texas and Scott from South Africa, do you want to say hello?
Just welcome everybody, and we always want to thank Seattle Science Foundation and Dr. Chapman, because they have been really the ones to allow to bring this to everybody. And we especially appreciate Sig Bervin and his great group from San Francisco. So we look forward to an interesting journal club discussion. So thank you, Sig.
Well, good morning, and thanks to the Seattle Science Foundation for, again, supporting some terrific opportunity for interaction. Our group at UCSF is certainly known for doing a lot of work with complex surgery, and we've presented in the past about some of the work we do with complex deformity, as well as tumors. And today we want to share with you another part of our back pain experience, which is low back pain. And specifically, we've recently received under the guidance of Jeff Lotz, who's our Director of Research in Orthopedics at UCSF, as well as Connor O'Neill and Patricia Zhang, who I think are joining us today as well. We've recently received a big grant from the NIH. It's the HEAL grant, as part of helping to end addiction long-term. And in this grant, our work is actually to specifically describe the phenotype of low back pain. So this is a multi-center research consortium to look at a description of the phenotype of back pain. And I'll invite all of you, I'm not going to take time during this journal club to tell you much more about it, other than the purpose of this work is really to recognize that chronic back pain is a priority for our healthcare systems internationally. And the burden of back pain includes social costs as well as economic costs. And our HEAL Initiative grant is now a $36 million grant to study both the burden of back pain and, importantly, the pathophysiology of chronic non-specific pain, to try and really understand from a perspective of structure, of radiographic characteristics, and also of social factors that lead to chronic back pain. And we've got multiple centers around the country that are contributing to enrolling patients. We're characterizing a cohort of patients with non-specific back pain. So again, patients who have chronic pain, oftentimes requiring opiates. And I thought what we do in this journal club is to really pull out a couple of articles that characterize both the problem of back pain, some guidelines with regard to management of back pain, and the relationship between back pain and our opiate crisis. So with that as a background of why we chose this topic, I'm going to introduce our first fellow, who is Amir Ghadarshi. Amir trained in neurosurgery at the University of California, Davis, and has joined us for his fellowship. Next year, he'll be joining the Kaiser group up in Sacramento. And Amir is going to give us an overview of the guideline summary review of an evidence-based clinical guideline for the diagnosis and treatment of low back pain. And this was from the NAS group. Please, Amir.
Thanks, Dr. Bervin. Good morning, everyone. My name is Amir Ghadarshi. I'm one of the Ortho Spine Fellows at UCSF. And as Dr. Bervin mentioned, today I'm going to be reviewing one of the systemic reviews. And the title of the article is Guideline Summary Review, an evidence-based clinical guideline for the diagnosis and treatment of low back pain. This guideline was published in 2020 in the Spine Journal and was produced by the NAS group. Specifically, the low back pain work group of NAS was responsible for producing this guideline. And they set out to create an evidence-based guideline to assist clinicians in diagnosis and treatment of non-specific low back pain in adult patients. They did this by really starting with looking at the wide variety of different practitioners and spine care specialists, ranging from primary care doctors, APPs, spine specialists, and surgeons themselves. And they asked them, what are some of the relevant questions that you have when you're dealing with diagnosis and treatment of low back pain? And the goal of the group was to create an evidence-based guideline based on the best available evidence that was published. They did start off by defining low back pain as musculoskeletal origin pain that extends from the lowest rib to the gluteal area and may intermittently include the thighs as well. And they did have exclusion criteria, which excluded back pain from tumors, infections, metabolic disorders, inflammatory issues, fractures, those patients that had a known deformity in their spine, those patients that had pain below the knee and had extra spinal sources of pain, patients that had prior back surgery, those with neurologic deficits, and those that had multi-site origins of pain. These are quickly just the grading criteria from NASS, essentially A through C, and then I for insufficient evidence, A being the best evidence and C being poor quality evidence. So there were 82 questions that actually were proposed and answered in this paper. Obviously, a lot of them had insufficient evidence because there's a lot of mixed results. However, I sifted through the paper and tried to find the questions that had the best evidence available to them. So we'll start off with one of the diagnosis questions, which was, what are some of the patient characteristics that can increase or decrease the risk of developing chronic low back pain after an acute episode? And then the second question that was relevant to this as well was that, does a psychologic evaluation assist in identifying patients with back pain who are at risk at developing chronic pain and disability? And so they came up with a couple of different answers to these questions. One being psychosocial factors and workplace factors should definitely be assessed when looking at patients converting from acute to chronic low back pain. Psychosocial factors should be assessed as a prognostic factor for return to work for patients as well, following an episode of acute low back pain. And then pain severity and functional impairment should be assessed by a clinician before stratifying a patient's risk for converting from acute back pain to low back pain that's chronic. And then prior episodes are definitely a prognostic tool in assessing if a patient is going from an acute episode and is going to have chronic back pain. And you can see the grade here of the recommendations are A's and B's, so fairly good evidence. The next set of questions were medical and psychiatric questions. And the question was, in patients with low back pain, are pharmacologic treatments effective in decreasing duration, intensity of pain, and also increasing functional outcomes for patients? And so it turns out that antidepressants are not recommended for treatment of low back pain. And as we all know, NSAIDs are the mainstay treatment. They're suggested for low back pain as well. Oral or IV steroids are not effective and should not be considered. And then, as we'll see in some of the other talks today, this was one of the recommendations that stood out. The use of opiate medication should be cautiously limited and maintained at a low duration for treatment of low back pain patients with non-specific low back pain. The next question was that in patients with low back pain, is topical treatment effective? And surprisingly, at least for me, topical capsaicin was the only topical treatment that was recommended as an effective treatment for short-term back pain, so 3 months or less. Lidocaine patches were actually insufficient evidence to make any suggestions on, but I have definitely in my training used those quite a bit. The next question was regarding, again, medical and psychiatric issues. In patients with low back pain, is cognitive behavioral therapy or psychosocial interventions effective in treating the back pain? And it turns out that CBT in combination with physical therapy versus PT alone can improve pain levels in patients with low back pain over a year. And then again, CBT in combo with PT against PT alone is suggested to improve functional outcomes and return to work in patients with low back pain. Next question was, what are the psychological factors for low back pain treatment that can influence a patient's outcome? So what psychiatric issues a patient could have that can actually affect your treatment modality? And the only one that came up with some decent evidence was that kinesiophobia, or the fear of movement secondary to pain, can have a negative prognostic value on the treatment, no matter what the treatment is. And I think it's fairly common sense. If the patient is not going to be participating in that treatment secondary to fear of pain, you can expect that treatment not to be as effective. The next set of slides will go through some of the specific categories that practitioners had questions against. This one was acupuncture. And in patients with chronic low back pain, addition of acupuncture to usual care was actually recommended for short-term improvement, both in pain and functional outcomes, compared with none of that. The next category was spinal manipulative therapy. It turns out with SMT, the results of SMT as compared to no treatment were very similar. However, there was no harm seen in patients that received SMT. There was short-term improvements that were statistically significant in SMT. However, the clinical significance was uncertain. Yoga was another modality that was asked about and showed that yoga was effective in treating low back pain in a medium, short-term to medium term, and patients had improvements in their pain and functional outcomes. However, again, the clinical significance of this was questioned because a lot of these patients have low baseline pain to begin with to be able to participate in yoga. And then aerobic exercise. I think everyone here is aware that aerobic exercise is recommended and improves pain, disability, and functional outcomes in patients with non-specific low back pain in the short term. Next category, and I think this is our final category, was the Pmr questions. This question came up quite a bit in patients with undergoing treatments for low back pain. What are some of the things in terms of the treatments that are different between bed rest versus active exercise? And again, unsurprisingly, turns out that those patients that exercise more and use exercise to facilitate their recovery are predicted to have better outcomes over time. And then lastly, interventions. The only effective interventions that was mentioned in the paper were thermal radiofrequency ablations. And this was done for those patients that were found to have facetogenic pain. And turns out these are quite effective for treating low back pain from the facets and can actually have a good relief for about 6 months. So in summary, identifying pain generators is quite challenging for non-specific low back pain. The NAS work group set out some guidelines to try to identify some of the interventions that may be effective for treating this pathology. And then some of the ones we looked at today with decent evidence were CBT, topical treatment, acupuncture, aerobic exercise, and PT, which all have a role to play in the treatment of low back pain. And obviously, I think there's a lot of room for further investigation and learning a lot more about how to treat this pathology effectively. Thank you.
Well, Amir, thanks for summarizing that first article. And the reason we included this is an incredibly thorough investigation looking at grades of evidence for low back pain, both diagnosis as well as some treatment modalities. And I'm going to invite Connor O'Neill, who I introduced earlier as the principal investigator at UCSF for our NIH HEAL grant, to maybe talk about the notion that low back pain really is such a heterogeneous diagnosis. And Connor, do you want to pick up on this with regard to guidelines? I'll let Connor interrupt me if he gets online, but specifically, a big part of the trouble with back pain is the fact that what we're dealing with in terms of chronic low back pain is a group of diagnoses that are really not at all a uniform pathology. So part of the grant that Connor's leading is specifically to try and look at some of the characteristics that include structural characteristics, biological characteristics, as well as psychosocial characteristics that may contribute to the chronicity of back pain. And Amir, one of the factors that you brought up was the idea of psychological testing, both in terms of predicting the likelihood of an acute episode of back pain becoming chronic, as well as perhaps guiding us with regard to the likelihood of return to work. And to that end, I wonder maybe, Rick and the fellows from TBI, can you share with us what you're doing with regard to assessment of psychological factors in your patients with back pain?
Well, Sig, as you said, we're talking about a heterogeneous population. You have the injured worker, and then you have the people that are not injured on the job, that, the weekend warriors that hurt their back. So it's really complex. And I will say that in the past, we used to treat a lot of work comp patients when the attorneys were allowed to represent them. But since they kicked the attorneys out, we see very, very few work comp. But we have, at the time when Andy Block, before he retired just a month or two ago, we had a full program where they, all work comp patients underwent behavioral medicine evaluation, especially mainly for the ones that didn't get better and went back to work. So the ones that developed chronic low back pain. And, it's a multidisciplinary problem. I think that we make a lot of the issues that we're overrun with too many pain management people that do too many injections without really any objective guidelines. So, this paper is great, but the problem is it's not the people that read the paper that we worry about. It's the people that don't come to meetings, the people that don't read the paper, that really don't look at all these things, and they're just churning the patients out. So I think the psychosocial factors are real important. So if you take somebody that's a ditch digger, and if I was a ditch digger, I wouldn't be able to do it. I have a bad back, but because I'm a surgeon, I can sort of, modify my own activities so that I put less stress on my back. But if I had to do anything heavy, I wouldn't be able to do it. So you think about it, psychologically, they're worried about providing money for their family. Their wife hates them because now, he's not doing anything. So it really is a multidisciplinary problem when it becomes chronic. The acute phases, I think, are relatively easy when you just follow these guidelines. In other words, you don't stick them on heavy duty narcotics. You try to get them into therapy and try to re-engage them with activities. So it is a huge problem, especially for the injured worker.
Yeah, and certainly we understand that the functional impairment of chronic back pain, the consequences economically in terms of work loss, and of course the consequences with regard to pain medications. You addressed that as well, Amir, in terms of pain medications, and you suggested that indeed we want to try and avoid that anti-inflammatories ought to be our first line. And then, but importantly, some of the things that are done quite commonly, the use of steroids, opiates that are done quite commonly. We're going to get to the opiate issue, but antidepressants were one of the things that were recommended against. At the same time, we know that some of the antidepressants are some of the norepinephrine inhibitors may actually have some efficacy, perhaps more for nerve pain than for back pain. But does anybody have a good guideline, or perhaps even does anybody in their spine practice work with a pharmacist who helps? And one of the challenges we've had at UCSF is the medical management of back pain is something that perhaps can be one of the most important interventions we have, yet access of patients to somebody who's willing to manage pain is incredibly limited. And specifically between prescribing restrictions, Jens, you talked about this earlier, as well as reimbursement. In a fee-for-service healthcare economy, people aren't reimbursing for managing the patient, for managing medications. People are reimbursed for doing procedures. And I'm finding that to be a major difficulty in trying to help patients with chronic back pain problems.
And Sig, you hit it right on the head. We see too many patients that have had so many injections over the years that in some cases they develop osteopenia. like 20 injections, and the pain management doctor thinks another injection is going to help them. I mean, just again, these are not the people reading the guidelines, unfortunately.
Yeah, I think we did a session previously on what I consider some of the maladies of our fee-for-service healthcare economy. And Jens, I think you particularly liked that one. We may touch on that again because there's no limit to what I considered maladies. And I think a fee-for-service healthcare economy leads to exactly that, where people are taking a piece of what they get reimbursed for, but there's a lack of accountability really for the entire integrated care. And it's so difficult in a fee-for-service economy to try and integrate care. And I've become a real advocate of Amir's going to be joining the Kaiser Group next year here in the Bay Area. And I've become a real advocate of integrated healthcare systems. And I think we need more of that in our healthcare economy to provide care for patients more comprehensively. Amir, I'm going to ask you to stop sharing your screen, if you would. And we're going to go ahead and move on to our next paper presentation. And this paper is going to be given about objective measures for functional impairment in patients with chronic back pain. And this is done by Sam Shabani. Sam is trained in neurosurgery as well. And Sam's training was at the University of Wisconsin up in Milwaukee. And Sam's actually returning to the University of Wisconsin-Milwaukee this spring to start his work as an attending there. So Sam, we'll give you the floor.
Good morning. Thank you. So as Dr. Berman mentions, I'm going to be talking about the objective measure of functional impairment for degenerative disease of lumbar spine, and it's a systematic review of the literature that was done. This is a systematic review of literature and tries to provide overview on available objective measure of function for patients with degenerative disease of lumbar spine. And as we know currently, there is a significant emphasis on prompts and health-related quality of life, but not much on objective measures of the patient functionality. For this study, they followed the PRISMA guideline and including specifically the criteria according to the PICOs. And part of that for the inclusion and exclusion criteria of the papers, I wanted to put in this systematic review. And also what they did was that they looked at a publication that were in English, German, and French language. For the selection criteria of the papers, they looked at papers with one or several objective measure of function, which is applied to human with a degenerative disease of lumbar spine. Objective measure of the functions were defined by task to be performed by the patient, evaluated using an objective assessment of patient's performance, rated by the observer and or machine instead of the patient, and based on the standardized testing protocols. And they only included patients with degenerative lumbar disease. They used different search machines in order to find for the citations. They had about 2,400 citations in the screening. And after putting the inclusion exclusion criteria, they end up putting, they only had about 82 citations in the systematic review. In terms of the disease types that were included, it was low back pain was about 34%. Spinal stenosis was about 82%. Disc herniation was about 26%. Listhesis or spondylolisthesis was 22%. They included vertebral body fracture, column fractures about 1-2%. And they had other types that they did not specify what is it exactly, which was about 4.9%, around 5% of the reviews. They had an interesting graph that they looked at a number of publications over years. And as you can see, during time, there has been increased publications on the objective assessment of the patients with the low back, lumbar spinal stenosis or degenerative disease. But in the last decade, there was a significant increase in number of publications compared to other years before that. They looked at a number of publications based on the countries. And as you can see, US is leading, followed by Switzerland, and then Canada, Germany, and UK. In this systematic review, they found 20 different types of objective measurements of a function, as they are included in this table. And they looked at the frequency of, in terms of the number of papers or the percentage they had that was discussed. For example, timed up to go was about 31% of discussion. Motorized treadmill test was about 30%. 5 rapid standing, repeat stand to sit test was about 11%, and so forth. What they identified was that the most frequently applied, reproducible, reliable, and validity objective measure of functions that defines were timed up and go, motorized treadmill test, 5 repetition sit to stand test, the self-paced walk test, the shuttle walking test, and the 6-minute walking time test. And for these 6, they went into more details in discussing them in the paper. I'm not going to go through the whole slides, but for the time up and to go test, they said that there's a good intra and inter-rater reliability. And it shows the highest correlations with the disability and walking capacity. And a change in at least of 3.4 seconds is considered to minimally clinically important difference for patients with lumbar degenerative disease. And one of the strengths of this test is that the patient's mental or smoking status affects the results minimally or none at all. In terms of motorized treadmill tests, it's a different studies have proposed different protocols in terms of the speed, time, or incline, and there is no clearly superior or gold standard to this study. Test results are that at the time of onset or significant significant increase in symptoms are considered. And they look for the results, they look at the total ambulation time, total distance walk, as well as the maximum walking speed for protocols that allow individual speed selections are recorded. In terms of the 5 repetition sit to stand test, one of the problem with this study is that the age, body weight, and BMI are shown to influence the result of the test. And in terms of the self-paced walk test, when they looked at it, self-paced walk test, they look at the maximum walking time of about 30 minutes. And the main test result is the total walking time. But the further they look at the distance to symptoms, the distance to first symptoms present, and the walking speed as well too. And the shuffle walking test is the test that the participants walk about a 10-meter course on the ground. And the test includes a maximum of 14 transits in 12 minutes with a maximum total distance of about 1,000 meters. And the 6-minute walking time is that the patients walk as fast as possible back and forth on a hallway for the 6 minutes. And the main result of the test is the 6 minutes walking distance. The paper had some strength and limitation. The strength of the paper was that they stated that in the literature, there is no previous study that as a whole look at all the objective tests that are available for patients with a lumbar degenerative disease. However, their limitation was that, again, it's a systematic review, and part of that systematic review included a couple of studies with a low number of subjects, and there's always a risk of bias in individual studies in the assessment of these studies. So in conclusions, what they said that was that based on this paper, there's no single gold standard for objective functional testing. There has been an increase in the reporting of objective measurements of function over the last decade, as we saw. And there's a profound heterogeneity concerning the types of objective measurements to be done. And some of the objective tests can be heavily influenced by other comorbidities, such as Parkinson, previous stroke, weakness, hip or knee arthritis. And that's all I have today. Thank you.
Sam, thanks for a terrific review of that paper. And the reason we included that paper is that this is a challenge that we deal with in all of our outcome studies. So again, we talked about the HEAL grant looking at outcomes and management of patients with chronic low back pain. But whether it's patients with deformity or tumors, how do we really measure changes in function? And that's a big part of what we're accountable for, right? If the goals of our care are to improve pain and function primarily, how do we measure this objectively? And in part, I included this because I'm curious about what other people are doing. We've been using questionnaires, including PROMIS, as well as ODI, which is a disability metric. But what are other people doing in terms of measuring objectively function as such an important outcome of our management?
This is a great question. Thank you for showing. This is Jens Chapman in Seattle. We've published on this, and I've actually failed in a grant trying to show biometrics being functional for spine surgery. The last point in the conclusions is so relevant. From what we found, roughly only about a third of patients qualified to have only single system, for instance, lumbar spinal stenosis. The comorbidity factors are so profound in this aging polymorbid population. So this is a serious issue that we've just not been able to overcome. The same, by the way, goes for attempts at trying to measure, for instance, myelopathy and try to quantify it. So this all has to be taken with a great grain of salt and a far more differentiated approach. Ultimately, I personally suspect that wearable biometrics will give us a far better big picture perspective on patients and their functional responsiveness rather than these artificial tests in clinics. That said, we can't just ignore it, and we have to try to improve. Thank you.
Yeah, Jens, thank you for sharing your idea about wearable biometrics. And again, this is a big endpoint of the HEAL grant. Connor, I'm not sure if you're on yet. We've got Matthew Smuck, who's working with us down at Stanford, doing a lot of work with wearable devices to try and get a better quantification of movement before and after surgery. We actually also had a grant from Fitbit, and we got 100 Fitbits from the company and measured activity before and after surgery for, in this case, deformity. What was interesting is that it seems that the determinants of that functional movement is something that doesn't correlate terribly well with patients' self-reported ODI, meaning reliably people had improvements of their self-reporting of disability, but oftentimes their movement might have been determined more by social factors or other factors. If they were in a lifestyle that just doesn't involve walking, they weren't doing 10,000 steps. In fact, it was quite a dichotomy. There was a group of patients who really got focused on their Fitbit and literally were doing 30,000 steps, up to 30,000 steps a day post-operatively in some patients. And then some patients really had no change at all, and the correlation with their self-reported disability was very low. But ultimately, I know Izzy's doing work at TBI with gait analysis, and that's something we've got an interest in as well. Our Shane Birch from our group has set up a gait lab in our new clinic, and hopefully we'll have some more objective measures of that. And any other comments or questions about functionally assessing or assessing function?
Sig, I think I can be heard now. I'm not sure. I was promoted.
Oh, thanks, yeah, thank you.
Okay. So yeah, I think it's a really important topic, and there's within the backpack research portfolio, there's a huge amount of effort around identifying quote unquote objective measures. And I think that you raised a really important point, is that probably a lot of it is related actually to psychological and social factors. And that probably hasn't been, enough attention hasn't been paid to that. And we actually have a trainee that's focusing on that, and he's found some really interesting things in looking at movement profiles using the Jeannie Bailey's system, the effect of those factors on movement. So I think we'll have more information. And I think a bigger issue though is really the use case for these assessments. What are we really trying to get? If the patient has the sit to stand is a second factor, but their pain is the same and their utilization of healthcare is the same, et cetera, what does that really mean? So I think that's, to my mind, sort of the biggest issue really around these different measurements. And in addition to what Dr. Chapman mentioned about the effect of comorbidities, not only physical, but also psychological.
Yeah, just introducing again my colleague and good friend Connor O'Neill, one of our partners at UCSF. He leads our non-operative spine group, and a really important part of our comprehensive management of patients with disorders. And thanks for your input on that, Connor. Let's move on to the next paper, which is transitioning now to the relationship between back pain and opiate use, and recognizing opiates as such a major problem of our healthcare system. So we've got Ravi Srinivas, and Ravi, if you go ahead and share your screen, and Ravi's going to talk about some patterns of opiate prescribing and some really notable variation in opiate prescribing between providers within orthopedics. So, and just background on Ravi. So Ravi actually did his training down in Los Angeles. He had done a fellowship in spine surgery with the group in San Diego, and was in practice for some time, and was really seeking to move his practice more towards complex pathology and spine-specific pathology. So he's come back and joined us as a very experienced surgeon, and he's done a terrific job as one of our fellows. And next year, Ravi hasn't actually yet decided where he's going to be going next year. He's got several terrific offers, and if any of you are looking for an excellent surgeon, then Ravi would be somebody to reach out to. So Ravi, take over.
That sounds good. Thanks, Dr. Berman. Can you hear me? Or is it...
Yes.
Okay, perfect. Okay, so this study is the notable variability in opioid prescribing practices after common orthopedic procedures. This is done by the group at University of South Carolina, and the study was published last year. So in a JAAOS. Okay, so just a little bit of a background here. The U.S. Department of Health and Human Services publishes some information about prescription opioids, saying that about 10 million people last year misused prescription opioids, and of those 10 million, about 1.5 million people were misusing for the first time. So significant problem. Americans consume about 80% of the global opioid supply, despite being a fraction of the world population. Drug-related deaths from opioids are rising. Obviously, pain specialists prescribe the larger number of opioids, but surgeons are the second highest in prescribing. And after surgery, as many as 1 in 16 patients can become chronic opioid dependent. The CDC recommends not giving more than 90 oral morphine equivalents per day, and we'll go through what that means. And this study basically looks at 10 common orthopedic procedures and essentially the pain medication scripts that were provided for these patients, and correlating that to the amount of opioids they were using. So again, there's 10 common orthopedic procedures that they used in this study. Anything from smaller soft tissue procedures like carpal tunnel releases, arthroscopic procedures like meniscectomies and rotator cuff tears, larger procedures such as arthroplasties and ORIFs for essentially wrist and ankle fractures. And then also they included pertinent single level ACDF studies. Single level ACDF surgeries. Where they're getting this information about the pain medication these patients were using is they're using a health insurance database called Truven Health Market Scan from 2015 to 2016. And basically this database contains how many prescriptions patients filled for pain medication, and essentially how many pills they were prescribed. And we're correlating that to how much medication they used. So we wanted patients that are opioid naive, which means that patients that have used opioids in the last year need to be excluded. If they got a prescription of pain medication in the last 2 weeks, we included them because some patients get their pain medication scripts early before actually going to surgery. And if anyone needed to have another surgery in the immediate 3 months or 90 days post-op, these patients were excluded from the study. And then we broke down the patients based on what part of the country they're from, the Northeast, South, Midwest, and West. So all the patients, so we get this insurance database, we have the prescriptions filled for the patients, and then we convert to oral morphine equivalents so we can compare the patients. And then we also look at the range of morphine equivalents these patients are taking within each subset group, depending on what part of the country that they're from. So oral morphine equivalents, just it's a nice way to standardize everything to morphine. So morphine is standardized at a 1. Common medications that we use here, we use oxycodone with a multiplier of 1.5. Hydrocodone stays the same at about 1. Hydromorphone, a multiplier of 4. And there's even larger lists than this that you can use. And there's online calculators that make it easy to use in clinic. If you want to watch how you're weaning your patient off of down to less and less more powerful pain medications. So the results of this study, this is there are about 74,000 patients that were classified as opioid naive, essentially not having narcotics over the past year before their surgery. In this slide, we'll go over, there's a lot of variability depending on the part of the country you're from, except for the arthroplasty patients. There's a wide range of opioids that were prescribed, and we saw that the West and the South prescribed more opioids. So, for example, you just look at the ACDF, the wide range. We have anywhere in some of these categories from 300 to 675 oral morphine equivalents. So initially after surgery, we have patients that are or at the very least being prescribed twice as much pain medication as other patients. And then if we go to the, so that's right after surgery, but now if we go, this is the 3 months after surgery, this is the total amount of pain and medication these patients took 90 days after surgery, again, transferred into oral morphine equivalents. Again, we see variability in the pain medication depending on what part of the country you're from, except in arthroplasty, it's pretty standard across the board wherever in the US you are. We have a wide variety of pain medication prescribed within each group. Obviously, the larger procedures like total knee arthroplasty will require more opioids, and smaller surgeries such as a meniscectomy or carpal tunnel release would require less pain medication. But again, you look back at the ACDFs and you look at the West, morphine equivalents over the 3 months immediately post-op, you have a range from about 400 to almost 1,200. So a 3 times difference in the amount of morphine equivalents of pain medication prescribed. Then they also looked at how often patients are refilling their pain medications. Again, variety and variability depending where you are in the country, and least refills, as would be obvious, again, for smaller procedures like carpal tunnel release, and larger procedures like total knees need a more refills of their pain medication. So what does this all mean? Essentially, there's no standardization of the of pain medication or an opioid prescribing practices across the country. There's variability across the board, and we know obviously the more complex involved surgery you're having, the more pain medication that will be required. Some of the data here, the CDC has reported that in 2015, opioid deaths were highest in the Northeast. This data that this study looked at from 2015 to 2016 showed that the Northeast prescribed the least amount of oral morphine equivalent, so the least amount of narcotic pain medication. What does this mean? It can be multifactorial, but there's authors that hypothesize that possibly this could mean that increased awareness of the opioid epidemic could be resulting in decreased prescribing practices. But again, there's no clear consensus about opioid prescribing practices. Limitations of this study, like I said before, essentially this is looking at an insurance database, looking at the pain medication scripts that a patient filled out, and we're assuming that that's the medication that the patient took, and we're assuming that they're taking it for that specific condition. For example, if they have a knee replacement and they're taking their Dilaudid for their or I should say, so they're taking their Percocet for their knee replacement. We're assuming that they're continuing that medication just for their knee, but if they also have, let's say, back pain also, and they just continue taking that narcotic pain medication for another medical issue that they have, there's no way to look at that in this study. And also, this study does not look into non-narcotic medications, which would be especially important, for example, in something like a carpal tunnel release, where you can get patients off the narcotics and on NSAIDs quicker. And then it also didn't take any anesthesia-related procedures like regional and extremity blocks, which would be commonly used for something such as a ankle open reduction internal fixation.
Ravi, that's a terrific review. Yeah. Again, really important topic that you're introducing now, the use of opiates and the absence of a clear consensus or a pathway for how to prescribe opiates in the perioperative period. I think it's a major problem of what we're doing in surgery. And I'll put this into context just briefly. And at the turn of the century, at the turn of the 20th century, Theodore Roosevelt appointed a fellow named Hamilton Wright to be the opium commissioner for the US. And Hamilton Wright at that time said that it's a major priority for us to limit opiate trade. And he said that of all the nations in the world, the US consumes the most habit-forming drugs per capita, and that was in 1911. So 100 years later, what's happened? Well, it's become even worse. That disparity, 99% of the world's hydrocodone, 80% of the world's oxycodone is consumed in the US. If you look at perioperative protocols for people after spine surgery or after arthroplasty surgery, how many opiates we prescribe compared to other countries, including Germany, is dramatically different. We're trying to change this right now, and love to hear what other people are doing with regard to perioperative opiate prescriptions and trying to standardize this.
Sig, I think a lot has to do with how you prep your patients. We tell most of our patients, again, I'm just talking from the standpoint of lumbar fusions and disc replacement, cervical fusion and cervical disc replacements. I tell most of my patients that if they are narcotic naive, in other words, they never had or they don't take them, is that most patients are often 4 to 5 days. And the power of the mental suggestion, I think, is real important. And fortunately, they changed the law in Texas where we can check and see where they're getting medications. And whenever we prescribe anything, we have to do a pharmacy check. And it shows where they've been getting medication. If they're getting medication from elsewhere, then we say, hey, we cannot refill this. The problem is that, again, a lot of the pain management folks will throw around the medications, very easily. So.
Jens, can you comment on a difference of your experience in Germany compared to the US?
There are actually dramatic differences. Thank you for asking that. One of the first major collisions I had when I came to the US in 1985 was as a resident at the University of Munich doing trauma surgery, and then at UT Southwestern in Parkland, the use of pain medications. At the University of Munich, and this was pretty much the German standard at the time, the nurse would basically have a general leeway to appoint pain medications, and they would distribute it very sparsely as needed. Very different from the US, where you had to write orders for regular pain medication intake. A recent study from Holland showed that for ankle fractures, we have in the US a 20-fold higher use of opiates compared to Holland, the Netherlands, for ankle fractures, assuming that the two cohort groups were rather similar. So there's a very significant cultural, there's a methodological, and there's a population-based difference in terms of how to manage it. And again, when you give a expectation of pain freedom to patients or to the population in general, then this will have to take into account that a significant abuse potential exists and that a significant habituation potential will probably take place. And the expectations of the population will shift. So having realistic expectations as to who your target population is and what the expectations are and how to eloquently and effectively discuss expectations so that function is improved is really an art and a very difficult subject because it's so multidimensional. Thank you.
I'll just add that in the chat, Dr. Aydin from Istanbul is logged in, and Dr. Aydin said he's now done over 4,000 lumbar stenosis surgeries using an MIS technique, and he's not had to prescribe opiates at all in Istanbul. So dramatically different than what we're doing in the States. Well, staying on the topic of opiates, I just want to get through one more paper that I hope you'll find interesting. And this is going to be presented by another fellow, Ali Mazid. Ali is one of our fellows, again, who's had experience in practice. Ali's been practicing for more than 5 years after a prior spine fellowship, primarily in Los Angeles, but also in Egypt. And he's come back to do more advanced spine training with us in preparation to join an academic practice. And again, Ali's not yet committed for next year. And so if any of the academic practices out there are looking for a terrific and experienced surgeon, one of the best surgeons, one of the best fellows we've had here, Ali's got, again, several options for next year, but still undecided. So Ali, talk to us about preoperative opiate use as a predictor of adverse outcomes.
Thanks, Dr. Berman. Can you hear me well?
Yes.
Okay, so following up on the last topic, I'm going to try to go quicker with this one. So this paper is about preoperative opioid use as a predictor of adverse post-op self-reported outcomes for patients specifically doing spine surgery. So a little bit of a background. As Ravi mentioned, opioids have been commonly used for pre-op pain management in patients with spine. Since 95, there's been an exponential increase in the opioid use with more than fourfold increase in 2010 compared to just 99. So on 10 years, fourfold, with increased dependence and the increase in the complications, as well as opioid-related death, up to 90% increase between 2002 versus 99. So a lot of studies suggested that the use is roughly somewhere between 33% to 70%. So the objective of this study was to assess whether pre-op opioid use predicts worse self-reported outcomes in patients. So in this study, they had a prospective cohort of 583 patients done by 6 surgeons doing spine cases at Vanderbilt University between 2010 and 12. The split of cases was 60% lumbar surgeries, 11% thoracolumbar, and 29% cervical. And the self-reported opioid use was converted into daily morphine equivalent, and the details about the type, amount, and frequency was obtained. They also obtained pre-op as well as 3 and 12 months follow-up, SF12, Eurocall, 5D, and ODI and NDI. And then they ran a multivariable linear regression analysis, and the evidence for this is considered prognostic level 2. So a little bit of the demographics in this slide. It's interesting to see that unlike the last paper, the insurance was pretty much evenly split between public and private. So, and also they ran a depression score assessment for those patients, as well as a modified somatic perception questionnaire, just to have the background about those aspects as well. They ran multivariable analysis for those measures, as we said, at 3 and 12 months. And the reported results, they found that 56% of the patients had in fact been using opioid, and they ran the analysis for age, sex, diabetes, and smoking, which showed interesting results as well as the somatic perception enzyme depression scale. Results were basically, they found that pre-op opioid use had a significant effect on the results as a predictor for decreased SF12 and Eurocall 5D, as well as increase in ODI and NDI at 3 and 12 months. And they had a sort of a linear relationship that for every 10 milligram increase in the daily morphine equivalent, that led to an 0.03 decrease in SF12 and an 0.01 decrease in Eurocall 5D, with an increase of 0.5 in the ODI. So seems to be a pretty linear relationship depending on the amount of morphine or narcotics used. One of the things they noticed that smoking as an independent factor did affect the ODI, caused an increase in ODI at 3 months, and diabetes had an effect at 12 months of increased ODI. So those are also other factors to consider. So in general, the amount of opioid consumption leading to clinically significant difference is still remains unknown, the specific amount. Many studies have alluded to the somatization and psychological factors that could be confounding for outcomes. I just want to quote this similar study by Lawrence et al. And they looked at 91 patients that did ACDFs, and they had a pretty similar opioid use of 50%, 52% of the patients. And the results showed that significantly lower incidence of the good and excellent results for the patients that use opioid, about 50% versus 86% good excellent in the normal or non-opioid using. Also, the poor results were much higher at 32% in that cohort versus 0% in non-opioid use. So there's a strong correlation with poor outcomes. So it might be very important to assess that and try to win that use before. So the strengths of this study, it's relatively large sample, 583 patients. It's prospective design. They have variability in elective spine cases between lumbar and cervical, and they ran a multivariable analysis for different measures. And the weakness, however, they did not account for the duration of pre-op use, whether the patient been using it for a month, 6 months, or several years. And they did not track the opioid use at 3 and 12 months. So this could be possibly an impacting factor on the outcomes. Although generally we assume that the higher the pre-op opioid use, potentially higher use after surgery as well. So in conclusion, increased pre-op opioid use, as well as other scores such as a depression scale and somatic perception questionnaire, led to worse outcomes and follow-up. This study outlines the benefit of psychological and opioid screening tests prior to surgery as compounding elements. And future studies need to be done to compare the outcomes between those who decrease the opioid use pre-op and those who don't. And hopefully that will give us a better guideline. Thank you.
Ali, thanks for presenting again another really important paper with regard to opiate prescription and the fact that the subset of patients who are using opiates preoperatively do have worse outcomes. And I'll tell you, at UCSF, we're screening now, as you've heard, looking at morphine equivalents, milligrams of morphine equivalents on all the patients. And patients who hit a threshold of 50 milligrams of morphine equivalents, we've shown that that subset have longer length of stay, higher readmissions, and the likelihood of them being on narcotics a year after surgery is higher. We've also correlated that with reduced benefit with regard to self-reported health-related quality of life. So we're trying now preoperatively to get everybody who's taking more than 50 milliequivalents of morphine per day preoperatively down below that threshold. We haven't shown if that's made a difference yet, but those patients are automatically getting a consultation with our pain management group before surgery. And I'm wondering, what are other centers doing with regard to managing patients who are taking opiates prior to surgery and recognizing that that's a risk factor for poor outcomes?
So it's interesting that, you mentioned that we try to get them down to 40 morphine equivalents. And, if they don't do it, then we don't do their surgery. And, we have them work with our pain management folks, with our psychologists to try to get them down. And, we try to explain how they become tolerant and try to give them some education of why their body needs more and more. And those that can do it, they usually will do pretty well. I don't have any data to show how long they stay on the medication, but we tell them our goal of doing surgery is to get them off the narcotics.
Yes, what about in Seattle? Any advice you've got from there with regard to opiate prescribing?
I second fully all of the sentiments and statements made, and have Bob Harty also. I'd like to have him comment also. This remains a very deeply frustrating situation because we're caught in a maelstrom of different agendas. There are many in our pain management world who say opiates and still insist opiates are not that bad, and we're bedeviling them as surgeons, and we're too unsophisticated. We do not have a functional service in terms of trying to get patients weaned off or detoxed from opiates. And again, we have a significant cultural divide with with some of our pain management colleagues who think that a regular dose is fine, and specifically a newer derivative semi-opiates like Suboxone and others are perfectly fine to use, whilst we personally really fear them as surgeons. Bob, do you have the microphone on?
Yes, I guess. Yeah, thank you. Thanks for the introduction, Jens, and great conference. Sigs, thanks for putting it together. I don't have a lot to add to this conversation. I think it is something that we're finally kind of coming to terms with. I think the physicians in the audience, maybe my age and Jens's age and older, will remember being forced to go through training in how pain was the sixth vital sign early in our careers as a result of an initiative really led by pharma rather than by physicians. And I think we're seeing the end results of that. I'll make a couple of quick comments. One is I think that the counterpoint or the flip side of this issue is there are now these patients that have been on high dose narcotics for months to years and have now then been caught in this situation where we are no longer willing to prescribe that and are really stuck with an addiction that may not have been their fault in the making. The second was a question I had for Dr. Mazia. This is a great study and very impressive data set and large data set. I wondered, did they separate out the patients who came in with morphine pumps? And I guess I'll make one editorial comment and then listen for your answer. I've always felt that morphine pumps are one of those things that if we are ever reviewed as a society, will be a red flag as to the level of corruption that we came up with a device to solve the problem in our biologic design by which our brains are not floating in morphine. So other than that, I have no strong opinions, and I'm interested in how they dealt with that in this study, Dr. Mazia.
Yeah, they actually did not separate, the route. I think they collected all the data in terms of route amount and frequency, but they did not separate the morphine pump as a separate entity, which would be an interesting thing because obviously they must take much higher, and potentially for future studies there would be a potential study there.
Yeah, certainly intrathecal administration, Suboxone and other formulations really make this a much more complex topic. I think we're out of time now, but I appreciate the opportunity to present in this forum and to introduce some more of our team. We look forward to sharing with you in the years to come some of the results we're finding out with regard to our work in helping to end addiction long term, and the NIH work led by my colleague Connor O'Neill, trying to characterize the phenotype of back pain and perhaps some effective interventions. And thanks again, everybody, for your participation.
Great job, UCSF.
Hey, great.
Thank you.
Thanks, Sig and company.
Thanks, everybody. Be well. We'll see you next Tuesday.
All right. Take care.
Bye-bye.